Alright, we're going to go ahead and get started on Module 2.4, which is altered mental status, which can be a very, very complicated topic to deal with as far as being a scribe in the emergency room. So here's our HPI, and this is actually a pretty good HPI. In fact, with altered mental status, you really don't usually get a lot of information. So we start with a 70-year-old male from nursing home, which is brought in by EMS with altered mental status. EMS states patient was last seen normal at 5 a.m. When staff went to check on him at 6 a.m., he was not responding. When EMS arrived, patient was unresponsive. He had a deviated gaze. Vitals were pulse of 90, blood pressure 170 over 100. Respiratory rate was 6. O2 sats were 90% on room air. Blood glucose was 100. No other information was provided. So, looking through this patient's nursing home records, his past medical history is diabetes, hypertension, Pick's disease, which is just an advanced form of dementia, and hypercholesterolemia. Past surgical history, patients had a gallbladder, cholecystectomy, appendectomy, and a small bowel obstruction. Social history, no smoking or alcohol history that you can find, and family history is otherwise unknown. So where do we start as physicians? So the ABCs, we're talking about airway, breathing, and circulation. So things move pretty fast if you have a patient that comes in altered. You'll see, first of all, we're going to be assessing the airway. This happens in any sort of respiratory arrest, cardiac arrest, trauma case, altered mental status, drug ingestion, whatever the case may be. So your airway is the patient talking? Is the patient protecting their airway? Is they drooling? Are they able to handle their secretions? Are they somnolent or tired, kind of out of it appearing? How we assess this on a exam is doing a gag reflex. So we'll take a tongue blade and we'll assess whether the patient has a gag, a diminished gag, or does not have a gag at all. These are all indications for intubation if they have a diminished or no gag reflex. That means they will not be protecting their airway and they need some sort of ventilatory support, so they will need to be intubated. So the airway, A, key number 1. B, breathing. Does this patient have spontaneous breaths? Are they actually breathing? Are they having equal breath sounds? Are they having shallow breathing? It's very important to assess their breathing status. Circulation is C, so we're assessing patients' pulses. Are the pulses bounding? Does the patient have a pulse? What's their cap refill? Are they actually perfusing their body? So again, very important ABCs. You'll see us kind of assessing our patient very quickly, whether this patient is going to need to be intubated, whether this patient is going to need CPR started. These are the 3 indications for starting those modalities. Our differential, huge differential. This is essentially outside a lot of the scope of this lecture and what we're going to be teaching you as scribes. However, these are the things that we think of. There is an actual acronym or mnemonic device, which is move stupid. So starting with the M, which is metabolic, do they have any sort of B12 thiamine deficiency? This happens in alcoholics. Typically they get a big thiamine deficiency and they can become altered. Serotonin syndrome, this is a issue patients have with SSRIs such as Paxil. A lot of the antidepressants can cause a serotonin syndrome when mixed with other drugs. O is for the hypoxemia, for the oxygen. So do they have low oxygen? Are they satting less than 92% on room air? Is this a pulmonary hypoxemia? Is there a cardiac hypoxemia? Or are they anemic, which is causing their oxygen to be low? This also stands for a high CO2. So when a patient comes in and they have COPD, typically they have a higher resting CO2 level because of their breathing status, because of their lungs. When you have high CO2 levels, it makes you altered. This is why we get ABGs and we're checking that CO2 level to see how far above 40 it is. When CO2 levels are 50, not bad. It could be the patient's baseline. When they're reaching 70, 80, 90, 100, these patients are becoming obtunded and they need to be placed on BiPAP if they're alert enough, and if they're not, they need to be intubated. Vascular causes, hypertensive emergency. These are patients that are having pressures in the 200s over 110s, and they obviously have some sort of altered mental status, so there's something going on. These are very different from the benign hypertensive patients that we have that come in 200 over 100 with no headache, no chest pain, no shortness of breath. Vascular, ischemic, hemorrhagic strokes. So very important to keep in mind. Vasculitis, MIs, acute myocardial infarctions. If someone has a huge infarct, they can come in altered. E is for electrolytes or endocrine. So we're looking at their sodium levels, their potassium levels, bicarb. There's various endocrine levels as well, such as thyroid. They're in a thyroid storm and their free T4 is through the roof. Seizures and status epilepticus. Whether or not this patient was seen seizing, you need to keep in mind the postictal state can be appearing. This could have happened prior to that 6 a.m. point when the patient was altered. Between 5 and 6 a.m., patient was seizing, and now the patient's altered. You need to keep in mind the differential of seizures and status epilepticus. And status epilepticus is mainly the seizure state where it's not going away with the Ativan or the Dilantin. They continue to seize and seize and seize. So it's a prolonged seizure status. T is for tumor, trauma, temperatures, toxins, lead, mercury, carbon monoxide poisoning, any of the toxidromes that patients may have if they're farmers and they've had some sort of ingestion of some sort of fertilizer. There's a lot of different toxidromes that patients can present with, and we look for that in their physical exam. The U is for uremia. So renal or hepatic dysfunction can cause patients' uremic levels to go up, which is your BUN on your BMP. So the BUN goes through the roof. The patient is not excreting this toxic level of uremia. Hepatic dysfunction or hepatic encephalopathy, we look for ammonia levels, which are typically metabolized through the liver. When patients have decreased liver functions, you can have an increase in ammonia, which can cause patients to become altered. P is for psychiatric or porphyrias. Porphyrias are kind of outside the scope of this lecture. Psychiatric, you've seen probably plenty of bipolar or schizophrenic patients that come in and they're not willing to divulge information, and we have to work them up for their altered mental status and make sure there's no medical cause for their altered mental status. Infection, sepsis, inflammation, urinary infections are big, pneumonias, any sort of peritonitis, any infection in the body can cause you to become altered. Lastly, D is for drugs, and this includes withdrawals, and you have anticholinergics, tricyclic antidepressants, SSRIs, which we've gone into, benzodiazepines, such as Ativan and Xanax, barbiturates, alcohol, obviously opiates and heroin. There's a lot of different things that can cause altered mental status, and it's a good mnemonic device to kind of sum up what it is. So as you can see, when these patients come in, we are very preoccupied, and our thoughts are right figuring out exactly, with the limited information we typically get, what is going on with this patient. Okay, so physical exam. So physical exam on this patient, we've already gone over the vitals, so HENT. So pupils are equal, round, and reactive to light. The TMs are clear. The mucous membranes are slightly dry. So this patient came in with a gaze deviation, and as you can see, there's no gaze deviation noted now on HENT. Neck was supple. There's no JVD. Chest, there was no crepitus, which is the crunchy sensation that you can feel when we're palpating the chest. We can tell if there's been a pneumothorax that's penetrated and caused some air leakage from the lung into the chest wall. So atraumatic. GI exam, soft. Bowel sounds are present and normal. The rectal exam, there's no gross blood, there's normal tone. Extremity exams, upper and lower extremities, there's no clubbing, there's no cyanosis or blueness, there's no edema. Pulses are present except for as noted in your ABCs. Back exam, atraumatic, there's no step-offs. Neuro exam, the very most important part of this exam. Cranial nerves, we typically will say 2 through 12. We exclude 1, which is the sense of smell. So 2 through 12 are exam, moving all extremities. Patient withdrawals to pain. There's no focal gross neurological deficits. Reflexes are symmetrical, but patient does not answer any questions, is not following commands, and patient is moaning, which we'll go into next with our GCS scale. So skin is well perfused. GU exam, perineum is atraumatic. Perineum is essentially just the genital region. There's no discharge and there's no lesions. The one thing that was left out on his physical was the cardiac exam, and cardiac exams are looking for we're looking for any sort of murmurs, which can indicate some sort of infectious endocarditis, some sort of valvular problem, which is causing them to be altered. Okay, so the Glasgow Coma Scale. So there's 3 different areas for the Glasgow Coma Scale. First is the eye opening, and I think of this as my own type of mnemonic is 4 eyes. So 4 eyes, 4 is they're open spontaneously. 3, they open to voice. 2, they open to pain. And 1, they have not opened their eyes at all. Verbal response, I think of this as the Jackson 5. So 5 is normal conversation. 4 is disoriented conversation. 3 is words that are incoherent. 2 is incomprehensible sounds. 1 is they're not verbal at all. Motor, I think of this as your 6-shooter or like a gun, so it's motor. So 6 would be normal. 5, they localize to pain. So if there's a painful stimuli, if we pinch their arm, they actually localize to that area. They grab that area with their other arm. 4 is withdrawals to pain. So if we pinch, they actually withdraw their arm from that painful stimuli. 3 is decorticate posturing, and 2 is discerebrate posturing, which is a little advanced for your knowledge base, but decorticate is where they will turn their arms inward, and discerebrate is where they turn their arms outward, and it's a posturing maneuver. And 1 is there's no motor at all. So obviously the top score you can get here would be 15. A patient, everything's normal, they're moving, their eyes are open, but they're disoriented, they're a GCS of 14, and that's typically probably the most common Glasgow Coma Scale that we have. Diagnostics. Shotgun approach, kitchen sink approach. When we have these patients come in, we're ordering everything. You're seeing labs drawn, stuff that we typically would never order, which would be ammonias. We can order lactates, thyroid studies, phosphates, magnesium levels, SAD rates, CRPs. There's a lot of different things that we order, and we're just kind of getting everything in there and trying to filter out the information later because we may not have enough time, so we want to get everything in at first blush. Another thing to think about, are they stable for imaging? Can they leave the ER? This is where those ABCs come in. Is their airway intact? Are they breathing spontaneously? Are they perfusing well? Their vitals are okay? Is this someone that can actually leave the emergency room and go to the CAT scan machine and be stable enough to sustain imaging? Or do they need to be intubated? Do they need to wait and become more stable? Do they need some sort of other intervention? So for diagnostics, we will always get an EKG. We're looking for acute MIs. We're looking for the intervals, which you'll hear us call out the QT interval or the QRS duration or the PR interval, widened QRSs, typical things that some toxins can produce. For chest x-ray, we're looking for pneumonias or sepsis appearing patients, infection, edema on the chest x-ray, trauma, pneumothoraxes, causes for hypoxemia. Head CT, we're looking for head bleeds, we're looking for any swelling, we're looking for masses, anything that can clue us into why the patient's not cognitive. Lumbar punctures, this kind of comes down the line if this is someone who we're suspecting is a possible subarachnoid hemorrhage. If the CAT scan is done within the first 6 hours, you can typically pick up a bleed, but after that time period you may need to add a lumbar puncture looking for some sort of microscopic blood infection in the lumbar puncture, meningitis, urine drug screen, drugs of abuse, or even just a urinalysis looking for infection. So documentation keys, as you can see with this lecture, things are moving fast and so should you. Continuous vital sign updates should be included in the chart. Continuous BP measurements, continuous pulse measurements, temperature should be stated in the chart, and stay abreast of the information as it's coming in. So document times for interventions. These patients, a lot of them will be getting Narcan to reverse opiates. They'll be getting D50 for suspicion of possible low blood sugar, thiamine if they're alcoholics. And if we look perplexed, we probably are. So there are some high stress times when we're dealing with these patients, and do not take it personally if your physician is a little curt and short with you, because we are trying to work this patient up as fast as we can to figure out that source. So if a patient comes in and they're young, we're typically thinking drugs. Patient comes in middle age, we're thinking acute coronary syndrome, or we're thinking drugs. If they're elderly, we're thinking UTI, or we're thinking drugs. So as you can see, there is a common theme. In the elderly, it's drugs such as medication effects. Young, middle age, drug abuse. Interventions you may see, intubation. Are we placing this patient on a ventilator? Are we defibrillating this patient? How many joules do we defibrillate at? Is it monophasic or was it biphasic? Have we started a central line? Is this an IJ? Is this femoral line? Is this subclavian? Lumbar punctures. What are we doing as far as positioning? Are we measuring the pressure? Foley catheter. We place this to measure urine output. So are we getting urine output from this patient? Are they septic? Arterial lines, these are placed essentially to get a continuous blood pressure. Bedside ultrasound. We're doing a bedside ultrasound to assess the cardiac wall motion. We're doing a fast exam if this could possibly be trauma that caused the altered mental status. All these things need to be documented properly. And as I said, things go pretty fast, so ask your physician what needs to be documented at the time when these interventions and modalities are being done. Okay, so this is a picture of your vitals or your monitor. So the top green is your tachycardic rate of 137. The second number is 99%, which is your oxygen value, your SpO2. The third value in red is your continuous arterial blood pressure from an arterial line. The third or the fourth number is number 20 in blue. That is your central venous pressure. That is typically, you can tell the volume status. We can drop a central venous pressure monitor if we're doing an IJ or subclavian. It cannot be done through a femoral line. This just helps with hypovolemia when we're giving fluids to someone who is in septic shock or any sort of shock state. The last number is your respiratory rate, and this we're seeing is 20. Okay, last slide, medical decision making, probably the most important part of this whole lecture. So, writing down, this is going to be a very full chart. You've seen obviously now our differential, which is huge. So we're trying to have you, as our scribes, outline our thought process. What are we thinking? What are we ruling out? What are we ruling in? Is there any family involvement at the time? Who's involved? Who is the competent person? Who is the POA? Who are we conveying this information to? Do we have a code status? Are they DNR, DNRCA? Are they full code? And then what is the prognosis? Is it grave? Is it serious? Is it fair? These things need to be included in a very full chart for alternate mental status, because we're not given a lot of information at the beginning, but as we work through this patient and more people become involved in the care, more information comes out, so we're able to better discern and better kind of filter through the things that are important in the patient's care. Okay, so that concludes our lecture in Module 2.4 on altered mental status.